So thanks very much, Philip, for the opportunity to be involved with this. And I guess moving on from Lachlan's theme about the fact that there can be transfer-related harm that doesn't necessarily meet the radar of VASM. VASM, of course, you have to die to get on Phil's desk. And I think it's really important that we consider the aspects of transfer in terms of benefiting and impairing patient care in terms of the whole patient care perspective, rather than just the very extreme ones that end in patient mortality. I think otherwise we run the risk of trying to understand sharks by just looking at shark bites. So this perspective on transfers is really about all comers, and in fact perhaps more on the non-urgent transfers than the emergency transfers. One of the reasons I suspect Philip invited me along is that occasionally I'm a little bit provocative. So I need to start with a disclaimer, and that is, while I work for a big metropolitan health service, the things I say are my opinions alone. These are not representative of my organisation. The perspectives have been drawn from working on 4 states in Australia and a few places overseas. And a number of these perspectives, I think, are common challenges that we're going to face. Why is my slide not moving? So a snapshot of my large unnamed multi-site health service, which has 7, soon to be 8 sites, 4 front doors, soon to be 5, otherwise known as emergency departments, and 5 intensive cares, soon to be 6, is if we exclude the emergency transfers in and around, we have somewhere between 1,300 and 1,700 patient transfers per month. Of these, about 200 qualify to be transferred with Ambulance Victoria. About another 100 are what are called HATs, or high acuity transport, which have an ICU or critical care nurse in the back, but not a doc or a paramedic. And about 100 of those are cancelled for one reason or another. So that just gives you a little bit of a picture of the size of this sort of activity. And unlike David, who was able to be very confident that all transfers or almost all transfers were completely justified, I'm going to throw some questions over some of those. I think there are a large number of motivations for transfer of patients, some of which are very justified, some of which are perhaps questionable, and some of which we have created by the system of healthcare that we have established. Obviously, among the patient factors are those who need specialist or tertiary need that's simply not available locally. Many patients transferred from regional centres to metro tertiary centres will be in this group. There are some that are transferred because they need timely access to care. But I'd argue that sometimes transferring a patient is a little bit like flying anywhere in Europe. It takes far longer and it costs far more than anybody can possibly imagine at the beginning. And sometimes patients are transferred because there is a perceived benefit or patient preference to be treated in a big place rather than a small place. But there are also clinician factors that drive the desire for patient transfers. There's clinician comfort for managing patients in a local environment. And I'm blaspheming a bit here this evening because, as Philip indicated, I'm now a paediatric subspecialist, and yet I question the transfers of many, particularly older children with general surgical conditions, to tertiary hospitals. I also speak as a subspecialist and suggest that some of the drive behind transfer of patients to specialist sites is around this relentless drive to subspecialisation. We have subspecialty centres or centres of excellence that have an alignment with areas of interest and health service priorities. And sometimes that means these are deprioritised, defunded or de-skilled in other centres. There's also an element of convenience, particularly within hospitals, of transfer of certain patients because home matches are much easier to win than away matches. And so occasionally we will move Muhammad to the mountain instead of considering moving the mountain to Muhammad, i.e. we'll move the patient to the clinician instead of the clinician to the patient. I think the wicked problems that sit in this are how we balance equity of outcome and equity of access. How can we have centre of excellence outcome in a loco-regional hospital in rural Victoria? The answer is we probably can't if the benefits of concentrated expertise are so strong in certain complex conditions. We know that high volume units foster high functioning teams. We know that high utilisation justifies the expensive infrastructure that can support this. I know that in order to be able to operate on a stone in a child, I need to have my patient be treated at Casey Hospital instead of on my home base at Monash Children's Hospital, because that's where all the expensive kit is. I do drive down to Casey for those instances. So I think we need to recognise that while there is certainly large benefits of concentrated expertise, particularly with complicated and complex situations, there's also considerable benefits in distributed care. The timely treatment close to home for the 12-year-old with appendicitis means the entire family isn't disrupted by being transferred 300 kilometres down the road. Maintaining a broad general skill base in regional and rural hospitals will allow adaptability to the unexpected to manage some of those more acute situations, such as the case Philip started with an elderly lady with intra-abdominal sepsis who may have benefited best from the best available care rather than transfer down the road. And it also provides an opportunity for continuity of care, familiarity with the local environment, ongoing provision of social supports, which is particularly pertinent at the ends of age for children as well as for the elderly. So I think it's important that we recognise that this pursuit of excellence can sometimes come at a cost. And if we're really interested in putting patients' interests first, we need to work out, we need to find some way of achieving that balance of when is the best available local care actually the best care. We know that in certain circumstances, time is critical. Time is brain, time is myocardium, time is testis. Transferring a testicular torsion 500 kilometres across the state because the patient happens to be under the age of 16 will almost certainly guarantee loss of said organ. The cost of patient transfer is also significant, not just in the fiscal cost, and very roughly for the sort of numbers we're talking in my unnamed institution, it's about $500,000 a month. But there's also massive cost in patient experience. Going back again to Philip's first case, the elderly patient who is transferred away from family for treatment that ends up being unsuccessful and then dies at a hospital a long way down the road is really disjointed from the family and the supports that are available. And if the intention was not for definitive care, that palliating the patient close to home may well have provided better patient, well, perhaps not patient, perhaps family experience in this situation. There are massive risks, and David talked a little bit about the behaviour around transfer in terms of disjointed communication, in terms of disjointed observations and medications. Various EMRs, different imaging systems and different pathology mean the information is not always available for the patient to have the best care. And so while I certainly concur with those 10 principles of behaviour that David outlined, I think it's really important to recognise that none of those dealt with the clinical decision-making that sits behind the is this transfer actually needed or not, and whether the consequences of the disjointed follow-up care and the handover risks are taken into account. So I guess my thoughts for this evening is, do we, can we, should we account for the risks and costs of transfer when we're making our clinical decisions about what's appropriate, about whether the best available is the best care in this situation? Should we, do we, can we account for these when we're looking at health service operational logistics? Do we encourage the moving of clinicians rather than the moving of patients where it's possible? Do we have the infrastructure and the procedures and the agreements for this to occur? And how should this influence the strategic design of future services, given that we seem to be building more centres of excellence and less general capable district general hospitals? They're all the controversial and blasphemous perspectives I have to share with you this evening.